The topic that I'll be covering is recent advances in reproductive genetics, transforming the reproductive health through genomic insight. So huge topic, and I think it's difficult to do justice in the time provided. But let me see how much I can go through. I'll try to simplify things and just put facts before figures to make things simpler. So recently there was this article which was all over the net, uh, even on social media, from the Guardian. So this was in Europe where it was found that a person who has been a sperm donor was carrying a cancer risk gene. And it is believed that at more than 67 children across Europe who were born by the gametes donated by this individual, and at least 10 children have been diagnosed with cancer so far. And now it's the task that is going on, tracing the children, doing the screening, and alerting the couples and all that. So we see that something like this hereditary cancers, though rare, but in a situation like this, how it could turn into a significant situation for the families, for the IVF centers, for the doctors. So when we talk of rare diseases, though we call it rare, but collectively they are common. The prevalence worldwide is like 3 to 6%. So we never know. And when we talk of cancers, particularly in India, a recent study shows that the prevalence for BRCA carriers in India could be way higher, somewhere between 1 in 150 individuals, quite high compared to the West. So therein comes the role of the ART or the IVF market, which is blooming in India. So the main purpose for IVF is when couples have infertility. But here, how we can use it to our advantages by identifying couples who could be carrying risk for genetic disorders, or who could be having genetic disorders running in the family, for whom we can screen, do the test, and as appropriate, couples who opt for, say, normal conception, we can provide options for prenatal diagnosis. Or in situations where they opt for IVF, we can do embryo biopsies, screen the embryos for particular genetic disorders, and just pick up the healthy embryos and do the embryo transfer, and the pregnancy can continue. So with this, even in the field of reproductive medicine, we are following or inching towards the era of precision medicine. So in precision medicine, the basic fundamental is like it doesn't follow this approach, one size fits all. Each therapy, each treatment, each disorder management has to be individualized based on the genomic parameters, the family history, the environmental factors, and other confounding factors which could influence the disease management, or the outcome in that particular individual or family. So awareness is important, and the same can be applied in the field of reproductive medicines. So presently, the challenges on this aspect that we face today is one is the lack of awareness. Second is the need for having more and more such centers which provide state-of-art facilities. We see that the number of prospective parents who are facing issues with reproductive health, with infertility, is increasing. Age of parenthood is increasing. Uh, Particularly the prospective maternal increases, age has increased past 60, past 35, and so does the risk of associated disorders, which could have an impact on a healthy and successful pregnancy. And again, genetic disorders are common that we have seen. What we call rare, collectively they are common. Carrier status in general population or even in families could go unnoticed, because carriers, they don't manifest with any clinical features. So only in situations where a disorder is manifested in the family, the suspicion is there, and in those cases, genetic consultation, testing, and all is done, and those families are followed up. But herein comes the importance, because certain disorders are common in general public, say like sickle cell, thalassemia, cystic fibrosis, and so on. Even spinal muscular atrophy in Indian scenario, where the carrier status is between 1 in 35 to 1 in 70, which is quite high. So for such genetic disorders, it should be the screening for any couple who's planning for pregnancy. These kind of genetic disorders should be included in the screening for such individuals. We all are aware of the Human Genome Project. It took more than 2 decades for one human genome to get sequenced and analyzed. But we have come to a stage where, in recent years, we have had a world record where entire human genome sequencing with bioinformatics analysis and the diagnosis has been done in less than 5.5 hours. And not just sequencing of one individual, but even we have come to a stage where we are doing genomics on a single cell. We are doing epigenetic profiling. The technology has evolved from short read NGS to long read NGS, and we have come to era of CRISPR-Cas, after which gene editing, gene therapies has received a fresh impetus. And again, in the field of metagenomics and microbiome analysis, with the advent of the NGS technology, the results are phenomenal. So when it comes to reproductive health, how the genetic field, at what all points we could touch upon. One is premarital screening, then preconceptional testing, advanced prenatal testing, newborn screening, that is post-delivery, then genetic screening in high-risk group, particular population, geographical pockets, or particular communities where there is increased incidence of particular genetic disorders. Ashkenazi Jew is a common example that we quote. We have similar population groups in India, the Sindhi group, the Parsis, where certain genetic disorders, hematological conditions are quite common. Then special situations which increase the need for oocyte or gamete preservation, particularly individuals who want to delay family planning because of, say, career choices or other reasons, or even in individuals who are diagnosed with cancer and have to undergo therapies which could put the gametes at risk. So, this gamete preservation could be done well in advance in such situations. And also, there's a we are seeing a era of IVF tourism in India, given the availability of world-class setups, all the testing facilities, and the technology that is available, and compared to the cost, which is very less compared to the West. So traditionally, when we talk of genetic testing technologies, it was fish initially, then karyotype, then PCR technologies, then arrays, and then last was NGS. But even in NGS, there was limitation in the technology where we were doing short read technology, and the required quantity of DNA was large. But we have come to a stage where we are able to do sequencing in a single cell. And with the advent of artificial intelligence models, the future looks really fascinating. So, in what couples or what patients, what test to do, which test to do, that is often the question that is asked. So, just to give an example, so if a male, we are dealing with a case of male infertility, there could be a number of causes. A few have been listed on the slide. And depending upon what clinical features the patient has, what abnormality is suspected, whether it is a chromosomal translocation or Y chromosome microdeletion or a monogenic condition like CFTR, uh, we need to pick up an appropriate test, because each test is done on a separate platform, separate technique. Otherwise, we may do a test and reports may come negative. So therein comes the role of medical genetic consultation and counseling to facilitate the test in these particular situation. Similarly, causes for female infertility, there are tests that needs to be done on appropriate platform. So whenever we talk of medical genetic test, the definition includes pre and post test genetic consultation and counseling. And then there are families where there is a history of particular genetic disorder. In those cases, the rule of thumb is identify the index case, the person who is affected, do the genetic test for that individual, identify the underlying genetic abnormality. And based on that, we do the screening of individuals at risk. And if there is any pregnancy which could be at risk, then we could offer them prenatal diagnosis by, say, chorionic pillar sampling at 11 weeks, amniocentesis at 16 weeks, if they plan for a normal conception. Or the other option could be doing an IVF, where embryo biopsy could be done and same genetic abnormality could be tested on the embryos just to identify the healthy embryos, and embryo transfer can be done. And once or in individuals where there is advanced maternal or paternal age. In those situations, options like PGTA, aneuploidy screening of the embryos could be done. In individuals where balanced translocations are known, we could do embryo biopsy and look in particularly for structural rearrangements in the embryos, the DNA of the embryos, or for monogenic conditions like, say, thalassemia, cystic fibrosis, or any other condition where the quality of life or the life itself could be threatened because of serious complications. Uh, those For those monogenic conditions, we can do embryo biopsy and a PGTM, or uh, pre-implantation genetic testing for monogenic conditions. So in all these situations, genetic counseling becomes important to identify the risk, to identify the carrier status, to go through the family history and correlate the genetic report to that of the clinical features in the patient or in the family member that is there. So these are various tests that we discussed. So basically, when we talk of pre-implantation genetic testing, whether it is PGTA, PGTM, or PGTSR, we need to remember that these are all screening tests. These are not diagnostic tests. Accuracy may be up to 98, 99%. But whenever we do any of these tests, it is always recommended that in the follow-up of the pregnancy, we plan a prenatal diagnosis, preferably an amniocentesis at 16 weeks, and do this test to identify or check if that genetic abnormality is present in the fetus or not. So that's a confirmatory test that needs to be done. So, having said that, so we look at the chromosomal abnormalities, the microdeletions, duplications, and the single nucleotide variations by all these techniques. We have similar tests when it comes screening tests when it comes to any routine pregnancy, what we call as dual markers or quadruple markers. And there is one condition that is really feared, that is preeclampsia, which is a serious pregnancy disorder marked by hypertension and proteinuria. It impacts like 2 to 4% of expectant mothers worldwide, leading to large number of fatalities and deaths. So recently there was a publication where the researchers, they tried to do a cell-free RNA test. So this is a microRNA test to identify uh, who could be at risk for preeclampsia. So this study had very interesting findings. So it showed that it could identify those individuals or healthy mothers who could be at risk of preeclampsia ahead of the onset of symptoms. And this was a simple blood draw. And this, again, though this is limited by the number of patients that were enrolled, uh, further follow-up studies are required. But this is a new avenue which sets out that even for conditions like preeclampsia, we can have genomic markers which can be tested to identify the risk in individuals even before the symptoms have started. Then for some conditions like just as we discussed, like hereditary cancers. So definitely for conditions where the life of the baby is at risk, multiple congenital anomalies could be there. The quality and outcome of the pregnancy could be affected in those situations. Definitely prenatal diagnosis or embryo biopsy testing is recommended. But in certain situations like hereditary cancers, now this is a matter of debate for some, but it is always the choice of the couple who want to avoid such uh, faulty genetic abnormalities from passing on to the next generation. So particularly like BRCA1, BRCA2, PALB2, and so on, where there could be risk of hereditary breast ovarian cancer syndrome. So this is just one example, but we have to remember that each parent, each and every person is likely to be carrier of some genetic abnormality, and it's a random chance that both of the partners could be carrier for some genomic abnormality. So it is always advisable for any couple who is planning marriage or planning pregnancy to have a proper medical genetic consultation before planning pregnancy. So any such risk can be identified, proper testing can be recommended, and the same information can be applied in the management of the couple. So when it comes to PGT in IVF, The efficacy and outcomes are definitely good. The success rates are higher. The number of cycles required to achieve pregnancy are less. There is a reduction in the rates of miscarriage with PGT. And again, the proportion of live births following the PGT and normal pregnancy outcomes is higher. But there is some limitation because there are few long-term studies, follow-up studies on PGT conceived children up to 4 to 5 years. Maybe more duration is required to have more robust data. But this comes with some technical challenges like the complexity of biopsy procedures, the embryo bring harm. Mosaicism is one point, one topic which has puzzled the IVF specialists. But the recent data suggests that for low-level mosaicism, the outcome is as good as euploid embryos. Then again, validation and of the studies and the clinical uncertainty, particularly if there are variants which are VOUS, then that poses a challenge for the clinicians and the IVF specialists for decisions going ahead. So the methods keep evolving, and from the invasive embryo biopsy testing, some labs have also started doing cell-free DNA or NIPGTA. But there are few studies and not much robust data is available on this. But whatever studies are there, the data looks promising. More larger studies, larger follow-up needs to be done on non-invasive PGTA. The real advantage in non-invasive PGTA is because whatever spent DNA is obtained is from the culture media of the plates where the embryo were cultured, and embryo biopsies directly avoided. So then there are other methods, techniques like gene editing and germline modifications. Some of the studies are happening in vitro. CRISPR-Cas9, which has opened up newer avenues of gene editing and germline modifications. Then fertility preservation. So that is one aspect. So as the awareness is increasing, lot many people for various reasons are opting for the preservation of the follicles uh, and gonadal tissue. So banking, rules, regulation, ethical practice on such fronts needs to be developed. Again, automated systems and AI and robotics is commonly being used and streamlined in the setup in IVF. And the most important aspect, which is often less discussed in all this, is the ethical aspect. So, proper consent, medical pre and post test, medical genetic consultation and counseling, keeping the IVF, the genetic disorder in question as a center point of this. Then having moral value for the embryos, risk and responsibility, eugenics and social impact, following the rules and laws of the land, that becomes very important. So in India, the PCPNDT and ART laws are very strict and stringent that needs to be adhered to, and having a regulation and oversight, and most importantly, awareness and reaching out, or particularly for those individuals who could benefit from such ART techniques compounded by the appropriate genetic testing technology, that becomes very relevant. So thank you.